Well, thank you, and for sticking out to the end. Okay, just a disclaimer, I am not a dermatologist. I've been working with Ann Lucky in the EB Center for about 10 years, but I do have a almost 40-year experience with GI and nutritional disorders, and especially in generalized inflammatory disorders such as Crohn's disease. And I think it's been well emphasized in this conference that EB is a multi-system inflammatory disease. And one of the messages I'd like to leave is it has primary and secondary GI and nutritional manifestations. So put simply for the GI tract, it's got to go in and it's got to come out. And something's got to happen in between. And you can see I don't have a good point on. Nope. These things are always different. Okay. GI tract starts with the oral cavity, the esophagus, the stomach. Most of the action as far as digestion, absorption occurs in the small bowel. Then you get to the colon, and one of the colon's main functions is to evacuate waste. Now, just some basic truths. Generally, the GI tract takes in nutrients, digests them, absorbs them. You're not even aware that's going on, and it excretes the waste, and everybody's happy. In EB, the GI tract functions normally in 99% of the cases, with two exceptions: the upper esophagus and down at the rectum, anus, with constipation. Another basic truth that we sometimes forget: energy balance. It's crucial, and you have to take in more than you burn up in order to gain weight, and in children, grow. And it takes about 15-20% of the daily caloric needs just to have normal growth. And the last point is that chronic systemic inflammation affects multiple parts of the GI tract and other organ systems and functions. Two other things I just want to add that can affect the GI tract. We talked about it being a multi-system disease, but chronic pain. Kids with EB have chronic pain, and they may have some chronic abdominal symptoms. Once you have chronic pain, you become hypersensitized to the pain, and I'm sure Ken Goldschneider talked about this earlier, but that can lead to a hypersensitive intestine, stomach, where you're getting real symptoms, but for minimal obvious reasons. And then all the psychosocial stresses that surround the child and family with EB can also compound the problem, can lead to increase in chronic pain, increased visceral hyperalgesia, and a vicious cycle. Don't expect anybody to remember these numbers, but these are just some proof that the average run-of-the-mill kid with EB has a chronic inflammatory status, whether you're measuring the common sedimentation rate or C-reactive protein or all these fancy acute phase reactants. They tend to be elevated, they correlate with the severity of the disease, and the more inflammation there is, the more difficult it is to control nutrition. Now, a take-home message: EB is a multi-system inflammatory disease. I don't think there's any doubt about that. EB may result in growth failure and malnutrition. Again, I don't think any doubt about that. Malnutrition itself is a multi-system disorder. And that's what I've spent my career looking at, is the effects of malnutrition on organ systems. But the last point is the important one. Malnutrition begets gut dysfunction, which leads to maldigestion, malabsorption, resulting in more malnutrition, resulting in worsening organ and immune functioning, which then leads to more malnutrition, and you're in this vicious, endless cycle like the hamster on a treadmill. Therefore, it seems rather obvious to me one of the things for the overall global health of any patient, we should be preventing malnutrition. Are GI problems common in EB? Well, if you ask a group of EB parents, you'd say, of course. But this is the largest series I'm aware of from Great Ormond Street. They had 223 patients with EB. 58% had a gastrointestinal problem. In EB simplex, gastroesophageal reflux and constipation were the most common. In junctional EB, it was poor weight gain, esophageal disease, and maybe some small bowel disease. PLE stands for protein-losing enteropathy, but that is controversial. In the dystrophic EBs, constipation, reflux, strictures, and nutritional failure are common. There have been some scattered case reports of chronic diarrhea and colitis in some of the recessive EBs, but really not a major problem compared to the others. So I break them down this way. It starts with the mouth. You know the kids with EB can have blistering in the mouth, they can have esophageal strictures, and they can have constipation, anal fissures that lead to strictures. But what people forget are the secondary complications, the malnutrition resulting in small bowel injury, further growth failure, and there are specific nutritional deficiencies which were alluded to, which have their own sequelae. Now, there's very limited specific data in EB, so we've extrapolated from a lot of other conditions where inflammation is predominant, such as inflammatory bowel disease. What causes the decreased oral intake? Well, a nutrient deficiency, zinc deficiency, can cause anorexia. The very state of inflammation causes anorexia. Just think of how you feel when you've got the flu. You don't feel like eating. Constipation unto itself can decrease oral intake. After a while, the gut says there's no more room for it. I'm not going to take anything in. We have the oropharyngeal issues, the mucosal blistering over time, the small mouth, the jaw that becomes fused, dental problems. The esophageal dysfunction, which is usually manifested by poor intake and then swallowing problems. And then last but not least, on top of all this, you can have the phenomena of chronic pain and depression, all of which result in inadequate caloric intake, malnutrition, poor weight gain, poor growth. So starting with the esophagus, progressive dysphagia or painful swallowing, difficulty swallowing. You can have strictures. They can be high and low. Now, if you're working with someone who is not used to working with EB and they're concerned about doing an esophageal study to look for strictures, make sure they look high. If you and we think you got a stricture because you got bad reflux, we're going to be looking down here. We don't look high. So the standard radiologist may not look high, and I'll show you that picture in a minute. This used to be a big problem. It's still a problem, but dilatation now can be done in virtually any medical center that has experienced people and gives you good results. Gastroesophageal reflux with concomitant vomiting can be a primary process, particularly in infancy. But as the child ages and the esophagus scars a little bit, it can lead to secondary reflux. Most of these are treated aggressively with a proton pump inhibitor, Prilosec, Prevacid, one of those. And this is what I was talking about with the strictures. Don't have a pointer, but if you look, you can see the teeth. And as you're coming down, that's the pharynx and the upper esophagus. It's slightly dilated and then it narrows. And that's a high stricture, which is where they're commonly seen in the dystrophic EBs. Then the esophagus kind of opens up a little bit, and then it gets down towards the bottom, and there's a long secondary stricture. The standard esophagram might miss that that high stricture. I get a lot of questions about the stomach and the small bowel. Well, just as a matter of fact, pyloric atresia, the pylorus is the end of the stomach going to the intestine, has been associated with junctional EB. That's obvious at birth, requires surgical correction. There have been scattered reports of small bowel changes, of protein loss in the intestine, but they've not been correlated with the degree of nutrition, the degree of malnutrition, and other ongoing intestinal problems. Because of the nature of EB, it precludes a lot of the normal invasive tests the gastroenterologists do. Sticking scopes down or up a child with EB, although technically not difficult, you run the risk of causing injury to the esophagus or the colon. As you know, anesthesia is no simple matter in these kids, so we don't do these as often as we do in other children. Likewise, for measuring reflux, the standard is to put a probe down the esophagus, tape it in place, leave it in for 24 hours. You can see what kind of a difficulty that would be in a child with EB. People ask me if there's malabsorption, and my answer in most cases is until you prove to me that the child is taking in enough calories, I'm not going to talk about it being maldigested or malabsorbed. The most common reason for poor weight gain in any chronic disease is inadequate intake. Constipation is almost universal. Anal fissures are common. They may progress to strictures. There have been rare reports of megacolon or very large dilated colons and a rupture secondary to constipation. Again, you can find, if you Google it, you can find scattered case reports of colitis. There was one case of ulcerative colitis in the EB simplex infant. Kindler syndrome, which is a specific mutation, can have severe GI tract involvements. The Great Ormond Street group has published non-specific changes in the colon mucosa, but it's very difficult to tell if that's primary or if it's secondary to prolonged constipation. And nobody really has done studies to see whether there is any significant primary colonic inflammation. You may be being asked to donate some stool in the future because there are now stool tests that are very reliable indicators of whether or not there's inflammation going on in the gastrointestinal tract. They're not specific, they won't tell you where, but they will give you a yes or no answer. I'll spend a moment on constipation. I'd say when I go to EB clinic, I spend 2/3 of my time talking about constipation and 1/3 of the time talking about nutrition. The main reason is painful defecation. And it can go on to develop blisters, fissures, and strictures. Chronic narcotic therapy hinders, impairs gut motility, so anything that can be done in the child's holistic care to decrease narcotic therapy would be a plus for the gut. We mentioned impaction, megacolon, and rupture. The issue is you have to anticipate it. You have to treat it aggressively and persistently. There's also a very new body of knowledge emerging that within the colon, the billions of bacteria who live there normally actually constitute what some people consider an organ system. They call it the microbiome, which helps regulate gut, colonic function, and growth. We know that the microbiome is disturbed by antibiotics. We know the EB kids are frequently on antibiotics, but to my knowledge, there have been no systematic studies of this and whether probiotics would in any way help. There's no evidence that they will hurt. So, prevention of painful bowel movements and avoid the psychological sequelae. If I can convince you of nothing else, please do that. Obviously, we want to improve the diet. We want to improve their fluid intake. They're most likely going to need some kind of laxative. There really are two types of laxatives. One's osmotic, Miralax being the prototype, it draws water into the colon and liquefies the stool. Stimulants, X-Lax, Senna, make the colon contract and help expel the loose stool. But you don't want to use a stimulant when you are dealing with hard, dry stools, because that will just cause cramps and pain. Most of us use Miralax or its generic components, polyethylene glycol 350. But really, anything works if the child will take it. Mineral oil, which I would not suggest in a child with swallowing problems, magnesium citrate, milk of magnesia, they all work. You just have to get the child to take it. But one of the messages is prolonged therapy is necessary. When the residents ask me how much Miralax, my answer is enough. I ain't got a clue what the dose of Miralax is. I can give you a milligram per kilogram ballpark dose, but the real dose is what your child responds to. And as I tongue-in-cheek used to say, I can't say it so much with cell phones anymore, but I used to tell the residents, Alexander Graham Bell did something wonderful. He invented the telephone. Parent can call us, tell us that 1 cap's not enough, go to 2. If 2's too much, go to 1.5. But each child is a little bit different. This is the feedback we get, not just in EB kids, but in constipated kids. Parents are afraid they'll become dependent on it. My answer, that may be true, but what's the alternative? We want to do it naturally. If you can get the kid to take enough fluid and enough fiber, have at it, but prevent the painful bowel movements. We can't find a dose that works. That's a matter of negotiation, trial and error between you and your provider. A common mistake when a child is impacted is the impaction is not dealt with. A dose or 2 of Miralax are given, maybe a suppository is given. You let off a little bit of the pressure, but the problem is still there. Parents have a natural tendency not to want to medicate their child every day, so they give it sporadically. And in the midst of all the other tensions and issues with a child with EB, making them sit on the toilet at a regular time after a meal, make them take their medication, really adds to the hassle. And if the child's not complaining, why would you want to do that? The reason you want to do it is you want to prevent the problem that is inevitable down the road. Spend the last few minutes talking about growth. The most common reason for growth failure is inadequate intake. Now, my specialist colleagues tend to focus on their organ, their disease, with the assumption that if they correct the organ dysfunction, everything will be fine. But meanwhile, malnutrition develops insidiously and causes secondary problems, as I've already mentioned. So our approach is we must recognize that nutritional status is important unto itself and to try and prevent or correct it while we treat the underlying disorder. These are the most common causes of growth failure. Inadequate caloric intake, we've talked about. Specific nutrient deficiencies, zinc being the prototype. The inflammatory cytokines, which are chemicals released by white cells, do inhibit growth themselves. And if the child is on chronic steroid therapy, that also inhibits growth. Years ago, many EB kids were on chronic steroid therapy. We don't see that very often anymore. But these are the sequelae of chronic malnutrition: growth failure, ultimate short stature, delayed onset of puberty, sexual maturation, immunodeficiency, which makes you more susceptible to infection and just sets off that vicious cycle. Wounds don't heal well if you're poorly nourished. Every organ in the body, including the heart, can be affected by nutrition, and there can be the specific nutrient deficiencies. And this is one thing I'd like you to remember, that the gut is directly affected in malnutrition regardless of the underlying cause. There's different mechanisms and outcomes, but in chronic inflammation versus simple starvation, but a vicious cycle is set up. Malnutrition results in gastrointestinal malfunction, results in maldigestion, malabsorption, results in malnutrition, and around you go. Bone disease has already been discussed, but assuring adequate vitamin D and calcium intake is obviously important, and in several studies, mobility has been the best indicator of bone disease. Here's a very complicated slide. This is from our inflammatory bowel disease population, but there's no reason to think the same would not be true in EBD, where due to the increased cytokines, reduced caloric intake, poor nutrition, growth hormone resistance develops, doesn't respond to what you are taking in, and the result is linear growth failure. In case I haven't made the point, the gut's infected and malnutrition, this is just a partial list of the things that malnutrition per se can cause within the intestine. But here's another take-home point. This is IBD, not EB. 48 fully grown young adults who developed Crohn's disease as kids. They looked at what their predicted adult height would have been from their growth curves before they became ill versus what their actual height was. Growth failure was common. Up to a third of these children, when they became adolescents, were stunted. And it was not correlated with age, the site, or age at growth cessation, but it was correlated with length of steroid use and times when they grew poorly. Now, a picture is worth 1,000 words. So here's two brothers. They're not EB, this is Crohn's disease, but I'm using it to make an example. Look like Tommy and Joe, ready to go out in the backyard and raise Cain, right? How about if I told you that they were twins? Not identical, but fraternal twins. They should have the same growth parameters. The boy on my right developed Crohn's disease. You can see he's a little Cushingoid in the face. And somebody somewhere missed his growth failure for about 4 years. He came to see us, we treated him. His Crohn's disease is under excellent control. And here they are at age 18. He looks healthy, but he lost inches that he's never made up. And this is the sad story of how we approached nutrition and Crohn's disease through my career. And I would submit to you that EB is sort of along the same path line. In the 40s to the 70s, we ignored it. In the 80s, we began TPN, but we rested the gut. In the 80s, we began feeding the gut. In the 90s, we got new medical therapies. In 2000, because our medical therapies were so successful, we started avoiding nutrition, and now we still see significant growth failure despite improved medical therapy. These have been alluded to, but these are the specific nutrient deficiencies that can occur in EB. Basically, if you can be deficient in it, it's happened in EB. So I would submit to you the most single critical screening test for the child's growth and nutritional status is the growth curve. If they're not measuring your child at each visit, plotting it, and talking about it, they're not doing their job. Which brings me to the gastrostomy issue. I know my partner, Jason Fisher, spoke about this. This was the initial report from Great Ormond Street. 18 kids with severe disease. They were all recessive. Overall, did relatively well. 1 hernia, 4 minor leakages, and 2 died for unrelated causes. But they noticed that over the years they were doing less gastrostomy. So last year they published their recent thoughts. They admit malnutrition and growth failure are common, especially in recessive. There's no doubt that gastrostomy improves nutrient and medication intake and improves growth. And the Cincinnati data also substantiates that. Patients who had a gastrostomy had better growth better nutritional status than those who did not. But there were significant hassles, mainly with chronic leakage and skin irritation. And who likes to have a tube hanging out of their belly? The development of the buttons has been better from that perspective. However, they took it a step further and they asked the families, what is your perspective? And there was a strong sentiment from families and from patients old enough to comment that they thought that having a gastrostomy overall significantly improved their quality of life. So we have to work on the skin problems, we have to work on the leakage, but I would not abandon the idea of assisted nutrition. So I'll close with saying in nutrition, our most important step is just to recognize it's an issue, monitor it, and intervene. There was a move a few years ago to talk about either or. Well, you don't need a gastrostomy, we'll just keep dilating your esophagus. I think the evidence is overwhelming that esophageal dilatation is good. Gastrostomies are good but have problems. Nutritional support, even starting with just increased caloric intake, is good. But I would submit the three are complementary, not exclusionary. The goal is to keep the child as healthy as we can in the best nutritional status that we can. Therefore, intervene early and prevent nutrition. And with that, be happy to answer questions. Go ahead.
Can you go back to the slide with the iron, zinc, selenium, and all of that?
With the what?
Can you go back a couple slides to the nutrient deficiencies?
Okay, I took it out, but which one do you have in mind?
I just take it full list. We got iron, zinc. We got
Iron,
I'll send it to you. I'll have it. Perfect. Okay, we got it.
iron, zinc, selenium, carnitine, and vitamin D, calcium, and then all the B vitamins. Basically, if you can have a defect, a deficiency, it's been reported, but the big ones have been zinc and iron. Yeah.
In your opinion, do you think it is a good idea for children with recessive dystrophic EB to receive a G2 prior to malnutrition? Be proactive before they have major skin breakdown and malnutrition and all the issues that happen, or do you believe that they should wait until they have to?
I'd split the difference. Yeah, the question was, do we just do it proactively or do we wait until they're malnourished? I'd split the difference, and that's why I was such a proponent of, and this is not just your dermatologist or your specialist, this is your primary care provider. Measure them each time they come and plot them, including the BMI, which is weight over height. As long as they're following their curve and their intake is okay, I'm okay. Now I got to ask you as the parent a question. How much of a hassle is it to get this kid to consume X calories a day? If you're spending 8 hours a day feeding them, that changes the balance. But just like Dr. Jeffrey said, when that curve starts to bend, we start having a conversation. One of the dangers, I haven't seen it too much in EB, but I've seen it in a lot of other conditions, is if you start gastrostomy feedings and you don't pay attention, one of the risks is obesity, because many of these children are not very physically active. So if you're playing catch up because you let the kid get malnourished to begin with, and now you blast them for 6 months to catch up and you don't turn the blaster off, when you see them in a year, it's a problem. Height, overall nutrition is probably best measured by height, weight, and some other indicators. There's other things that impede the height growth, and that includes the chronic inflammatory state, the bone disease. So you got to tackle them all. That's where the BMI becomes helpful, because the BMI looks at the correlation of height and weight. In this country today, we've got 90% of our problems are on the high end of the BMI curve, but most EB kids are on the low end. And when they start dropping below about the 10th, and certainly if they get below the 5th percentile for BMI, it's, why? And it maybe they're growing in height and not putting any weight on, so their BMI is dropping. And just as a BMI over the 90th percentile is associated with bad outcomes, so is a BMI below the 5th percentile. It's a U-shaped curve. So Jen Phillips, who spoke yesterday, our dietitian, every visit, she calculates, plots the BMI, and when it's starting to drop. Now, if this child were able to eat, the first thing I'd do would be extra calories, but we'd have the conversation. And I'd rather have the conversation, back to your question, I'd rather have the conversation early and say, I'm not concerned now, but this may be where we wind up, and this may be what we want to do, and here's some information, and you go think about it, so that I don't walk into the room one day, 2 years from now, and say, your child needs a gastrostomy tomorrow, and you look at me like nobody ever told me anything. And each family will make a different decision at a different point in time. And how strident I am about it will be different at different times.
Is it recommended to have a nutritional panel screen for nutrient deficiencies, like on a subclinical level, like not waiting until we see a health problem developing and manifesting itself?
In Cincinnati, every 6 months to a year, we just draw a nutrition panel measuring vitamins, carnitine, trace metals, and begin supplementation early. I mean, one advantage, if you're using a commercial diet through a gastrostomy, you're pretty sure that those have the RDA of all the major nutrients in it. But when you're on an oral diet and a child is a picky eater, may be a problem.
Right, like could we, give just a commonly available vitamin, like a liquid vitamin supplement, but I don't know.
We recommend, now, you get into a problem, can the child swallow a pill? And getting all the complex vitamins in a liquid form can be challenging. But, yeah, and I'm a big advocate for zinc and iron early on.
Or do you have a suggestion about like maybe a compounded, a compounding pharmacy? Would that maybe be a better alternative to like a common, over the
If they'll do it, and if it's palatable, yeah. I mean, compounding pharmacies can be your friend or your enemy. So if you have a good one that works with you.
My daughter does the same thing. Used to do the iron, used to take iCar, but now iCar is off the market. And I know you could take that in higher doses. Do you have a recommendation for a form of iron to take?
Orally,
Yeah.
iron absorption is improved if you have vitamin C with it. So some of the compounds like Ilex contain vitamin C, and that's probably the best compound. Iron's absorbed into duodenum, so in 99% EB kids, there's not duodenal disease. It's just a matter of getting it in. I'm blocking on the name now. It's terrible, it'll come to me. But if you just Google iron plus vitamin C, it'll come up. That's terrible, getting old. Go ahead. I can sympathize. My grandmother gave me cod liver oil every Friday. Because she was Irish and that's what they did in Ireland. There is one point I didn't make. There's a gentleman, I believe it's a gentleman, could be conceivably be a woman, out there who wreaks havoc, and the name is Dr. Google. Don't just put in some symptom and see what pops up. There's a lot of charlatans out there. Go through a respectable website like DebRA and then out to a good nutrition site. And the surest sign of quackery to me is if they say you need something, which only they sell. But, be careful, or, contact the dietitians in your local EB program or us, and we'll give you the best advice we have. We still have a lot to learn, but I think we can prevent a lot of misery.
You have to study it because there is so much bad information out there. And there's a lot of good information, and you have to know the difference between the two. But there's a lot of people all over.
I agree. Well, thank you.